Hello. Am I audible? Hello. Hello. Am I audible?
Yes, doctor.
Yes.
Okay, that's great. So, okay, really sorry for delay. Okay, I apologize on that. Okay, so today, as you guys know, that we'll be discussing lumbosacral plexus, right? So we discussed the upper arm, everything. Now we'll be discussing the lower limb and everything, right? So lumbar plexus. So we have plexus. We discussed before we have brachial plexus. What are plexus? We discussed that they are basically bunch of nerves which basically supplies your different, in upper limb we discussed it's going to supply different muscles in your upper limb, and it's also going to supply the lower limb as well. Same as that of for lower limb, we have lumbosacral plexus. Like in the lumbar region of your body, you have certain plexus or collection of nerves, as well as in the sacral region. Collectively, they are called as lumbosacral plexus. And what are the goal of they? They are basically going to supply muscles in your lower limb, along with sensory supply to the skin. That's the goal of your lumbosacral plexus, right? So you can see here that lumbar plexus are basically network of nerve which arises from T12 to L4, right? In the lumbar region, they're going to supply the muscles of your lower limb. Along with that, they're also going to supply, have some sensory supply as well. So these are the plexus you guys can see. The lumbar plexus marked in green, arising in the lumbar region. Then we have our sacral plexus. So the sacral plexus basically again they are group of nerves or mixture of nerves which arises from the sacral region from L4 to S4. That's why we just call them sacral plexus, and they're also going to supply certain muscles in the pelvis and lower limb, which we'll be discussing in a bit. Okay, so let's discuss some of the nerves from lumbosacral plexus. So the first nerve which we are going to discuss is iliohypogastric nerve. Really important, really high yield. You are going to have a lot of MCQ on iliohypogastric nerve, right? Okay, do you guys know what is hypogastric region? Hello.
Yes. Above umbilicus, above suprapubic,
Okay, so this
Below.
is basically you
Below the
hypogastric region, right? That is below the umbilicus and above your symphysis pubis, right? That's basically you or your pubic bone. That's your hypogastric area, right? So iliohypogastric nerve. Iliohypogastric nerve is going to supply certain muscles along with sensory supply to the hypogastrium. Which muscles do iliohypogastric supply? They are internal oblique and transversus abdominis, right? So you guys can see here, this is your internal oblique muscles and you have your transversus abdominis muscle, right? These are the muscles of abdomen which basically your iliohypogastric supply. It arises from T12 to L1, and the sensory supply is going to be suprapubic or hypogastric region. This is hypogastric or suprapubic, above the pubic bone, right? So you have motor and sensory supply. Motor and sensory. Motor to the two muscles, which is internal oblique and transversus abdominis. Internal oblique and transversus abdominis. The sensory is going to be suprapubic region, suprapubic area, the hypogastrium, right? So below the umbilicus and above the pubic bone, it's going to be the nerve supply of, or it's going to be, iliohypogastric nerve supplying different region. Okay. Okay, so how does iliohypogastric nerve basically get injured? That's really important to know, right? So it can be injured in during like laparotomy, during laparoscopic surgery. So if you guys remember in laparoscopic surgery, we basically do a lot, the 2 to 3 holes in the abdomen, right? One of which is here below the umbilicus. Remember, There we just insert a trocar, and inside the trocar we basically undergo a procedure. We have to there are big scissor kind of structures just handled here, if you remember, right? Right? So if we have a transverse cut here below the umbilicus for that big trocar where we insert the camera, if you remember, right? So through the camera, we are just observing this entire procedure in the laparoscopic surgery. So it can lead to damage or impingement of this nerve iliohypogastric. So for example, if you are just taking stitches, it can just impinge, after the surgery, it can impinge this nerve, leading to injury of iliohypogastric nerve, right? Similarly, hernia and hysterectomy. If a female is having certain kind of cancers, ovarian cancer, and cancers, for that, if hysterectomy is indicated, it can also lead to problem in this nerve because we are going to cut the abdomen, at this part. Okay. Besides that, the transverse incision, as we discussed, can also lead to, and the sutures itself can thread the nerve, right? It may also involve ilioinguinal nerve. So what is ilioinguinal nerve? Do you guys have any idea of that? Hello? Ilioinguinal nerve basically comes in the inguinal canal, okay? Just like that. Okay, and it basically supplies certain region here in the scrotum, sensory region, or mons pubis. This is going to be one of your UWorld MCQ as well. So the ilioinguinal can also get damage in association with iliohypogastric nerve, right? Which we'll be discussing in our further modules, right? So the system, the symptoms which an individual is going to experience after having any impingement or having any problem with iliohypogastric nerve is burning pain and paresthesia, tingling, right? Where the region where it supplies, that is suprapubic area, right? Sometimes in the labia and the scrotum or thigh as well, right? So sometime, if I just mentioned, if the ilioinguinal is involved with your iliohypogastric, so we can have these problems, tingling sensation, paresthesia near the labia and the scrotum as well, in male or female, and the thigh, because ilioinguinal supplies these area. That's basically the sensory supply. Is it clear? Hello? Hello?
Yes.
Okay,
Yes.
perfect. So the next nerve which we are going to discuss is genitofemoral. It means it have two components, genital component and femoral component. Okay. Okay. Remember, in the genital component, it's going to supply a muscle. Which muscle? That's a cremasteric muscle. What is cremasteric muscles? We know that, for example, just around the testicles, we have a muscle called as cremasteric muscles, which we look for the activity of this muscle is going to be seen in a reflex, which is known as cremasteric reflex. What is cremasteric reflex? If we just tap, or if we just stimulate the thigh of an individual, we are going to be having ipsilateral raise of our testicle due to contraction of your cremasteric muscle, right? So it means that in cremasteric reflex, we are looking for activity of which nerve? Genitofemoral nerve. Why? Because the genitofemoral, the name genital indicates that it's going to supply the cremasteric muscle, which is in close communication with your genitals. Am I right? Hello? Hello? Hello?
Yes. Hello.
Yes. Yes, doctor.
Okay, perfect. So the muscle which are covering the testes, we discussed. So if the upper medial, if the upper, okay, what's the femoral component? It's going to supply. It's a sensory supply, right? So the genital portion is a muscular. Which muscles is going to supply the cremasteric muscle? The femoral is it going to supply the upper anterior thigh. Thigh is your femoral region, right? So it's going to supply the upper anterior thigh. Along with that, the muscle supply is going to be your cremasteric muscles, which we see in cremasteric reflex, right? So it's also going to supply some sensory innervation as well. That is to the skin of anterior scrotum in male. In female, it's also going to supply the skin over mons pubis and labia major, right? So that's really important to know. Genitofemoral nerve. How does the genitofemoral nerve get injured? That's really important. Do you guys remember of something called retractor blades? Hello?
Yes, in use in general
Yes.
surgery also.
Yes.
No,
Retractor
doctor.
Yes,
use.
in general surgery. Perfect. If we are just cutting through the abdomen, right? So we have just blades like that, right? Retractor blade. So we basically
Yes.
had hold this skin component and we just pull it out, right? In order to have a proper view of abdomen, right? So
Yes.
through the pull of those retractor blades, they can damage your genitofemoral nerve. So it's going to supply the sensory innervation somewhere here. So if you're just pulling it through the retractor blade, it can lead to injury of your, yes, injury of genitofemoral nerve. Is
Can
it
Gentle.
clear? So as a
especially
result of
opening
that,
one
what would happen?
nerve here.
An individual is going. Yes, perfect. Okay. So what would happen? We are going to be having absent cremasteric reflex. We know that, right? And we are also going to be having decreased sensation in anterior thigh because that was the regions and the muscles which your genitofemoral nerve was supplying. We know that, and that makes sense. That's simple, right? Okay. Okay. The next one which we are going to discuss is lateral femoral cutaneous nerve. Lateral femoral cutaneous, as the name indicates, cutaneous. The word cutaneous that it's only sensory, sensory, no motor component of this nerve. Okay, lateral femoral. It's going to supply the lateral femur somewhere here, right? Or the lateral thigh, I would say. Am I right? As the name indicates, it's lateral femoral cutaneous. The lateral thigh only cutaneous, only skin, right? So it's going to course under the inguinal ligament. We know the inguinal ligament is going to go below the inguinal ligament. And those who are obese and they wear tight clothing, they can compromise this nerve. They can compress this nerve, which would lead to something called, yes, that's meralgia parastatica, right? So what is meralgia parastatica? Once, okay, lateral cutaneous. You can see this is the lateral thigh and cutaneous, only the skin, right? Okay. So in lateral femoral cutaneous, meralgia parastatica, that's also known as outer thigh syndrome, in which you are going to be having burning sensation, paresthesia, and hypoesthesia diminished. And why is that? In obese people, if they are wearing tight clothing, it can compromise this nerve. And once this nerve is compromised, you are going to be having meralgia parastatic and distribution of this nerve. And what's the distribution? The outer lateral thigh. Is it clear? Okay. Am I right?
Yes, sir.
Hello.
Yes, you are.
Yes, yes.
Perfect. The next is obturator nerve. What's the function of obturator nerve? That's really simple. So as it's a Latin word and it means to close. So how do I close my thigh? If this is my thigh or this is my leg, to close a thigh or to aid it towards your body, we are going to use adductors. Am I right?
Yes.
Hello. So can I say
Yes,
that obturare, which means to close? Can I say they are going to be the nerves which are going to supply all of your adductors? Can I say that? So whenever you see obturator nerve, it supplies all of the adductors because the word obturare means to close the leg or to adduct the leg, to bring it close to your body. That's adduction, right? And which muscles are they? They're really simple. Their name have adductor longus, the big one, adductor brevis, the small one, the adductor magnus, really big one, okay? The gracilis and obturator externus. We are going to discuss each and every muscle once we just move to our next slides, okay? And medial thigh. The sensory is small portion of the medial thigh is going to be supplied by your obturator. And most of adductors, which are also going to be present at the medial thigh, right? So adductor would be having somewhere innervation and insertion here. As we just pull them, they're going to aid the thigh, which are going to be supplied by which nerve? Obturator, right? Because the word obturator means to close. So obturare Latin to close is going to close your thigh, adductor longus, brevis magnus, gracilis, obturator externus, which is going to be your medial thigh. Is it clear? Obturator nerve. How does the obturator nerve get damaged? That's really important, right? So you can see here the course of obturator nerve, right? So it courses through the posterior pelvis. Here you can see the obturator nerve. It passes here through posterior pelvis, somewhere here, okay? This is your obturator nerve. It passes through posterior pelvis. So whenever we are doing any kind of pelvic surgery and we insert the trocar, we discuss what is the trocar. If you remember, it's only going to be a hollow tube through which either we can insert camera or through which I can either in the laparoscopic surgery we were just inserting camera or we were just using those big scissors to undergo our procedure. So in the pelvic any kind of pelvic surgeries, if you're just inserting this trocar, right, into the pelvis, so sometimes it can lead to compromise of obturator if you have deep penetration of that trocar. And as a result of that, you will be having a weak adduction. We know that. And numbness to the medial thigh, because small portion of the medial thigh is also going to be supplied by this obturator nerve, as we discussed here, right? Is it clear? So it's really important. One of like you're going to have a lot of UWorld MCQ. They're going to ask you. We have an individual. He was having some pelvic surgery. We inserted a trocar, really deep. What do you think? Which nerve is going to be compromised? So there's going to be your which nerve? Obturator nerve, right? Other one is femoral nerve, and it's very simple. The femoral nerve is very simple, right? So it have both motor and sensory innervation. It's going to supply the anterior thigh muscle. In the thigh, anterior thigh, we have a group of muscles which we are going to discuss, and it's going to supply those muscles. If they're present in the thigh, what would be the function of those muscles? Really important. They will lead to flexion, or they are going to be causing flexion at the hip joint, but extension at hip flexors and knee extensor. So if this is your big thigh, your leg, so the group of muscles which will be present here, they're going to extend just like that. Okay. So if I'm just, pulling them from their origin side, so what happens here? We are going to be having flexion. Am I right?
Yes.
Hello? And if I'm pulling them here from the origin side, here that will lead to extension, right? So flexion of hip joint, or flexion at hip joint, and extension at knee joint. Let's discuss these group of muscles which your femoral nerve supply. The first one is your pectineus muscle. So you can see this is your pectineus muscle. This is your pectineus muscle, right? So it's basically going to be your hip flexors, right? So if I'm just pulling this muscle, what would happen to this joint? What do you think? Hello? Pectineus. Flexion.
Right.
I'll just pull it up, right? Which is going to lead to flexion here. Okay, iliacus. So you have this big muscle, iliacus, which is coming down, and it's again inserting on this part of your femur. So if I'm just pulling this muscle from this side, what do you think what will happen at this joint? Again, flexion. And then you have this big sartorius, right? Okay. So if I'm just pulling this sartorius, again, it's going to lead to hip flexion. Okay. These are your hip flexors. Okay, the other one are your quadricep muscles, which are present in the anterior thigh. So as the name indicates, quadricep, we have 4 muscles, right? Quadra. The word quadra means 4 muscles. The rectus femoris, you can see this is your rectus femoris, this big, right? Vastus lateralis at the lateral side. Vastus medialis just below the rectus femoris. Vastus intermediatus, intermediatus is below the rectus. So the rectus femoris, and medialis is towards the medial side, and that makes a lot of sense, right? So you have rectus femoris, the one to the lateral is vastus lateralis, the one to the medial side is vastus medialis, and the one in between is that is below the rectus femoris is going to be vastus intermediatus, right? There's going to be intermediate present between, right? So the femoral nerve, what's the function of femoral nerve? Do you guys know what is patellar reflex?
Yes.
Hello?
Tapping.
Before, Mhm.
What is a patellar tendon with a hammer, and then there will be extension of the knee joint.
Leg, yes.
Okay, extension. Perfect. Okay, so for example, if this is your patellar bone, right? So we know, if you remember, I just told you that these quadricep muscle tendons are going to move over the, the patellar bone inserted into tubular tuberosity. Remember? And you also have a patellar tendon as well. Am I right?
Yes.
Hello? So first of all, you should know what is reflex, right? We know that we have a monosynaptic pathway, that is an afferent and efferent. Reflex is any kind of movement which does not travel your brain, right? It does not travel to your brain. The pathway is present within the spinal cord, right? That's a reflex, right? It means they have a synaptic pathway. If you're just striking this muscle, or striking this tendon is going to increase the tension within the muscle. Am I right? And as the increased tension is sensed in this muscle, it would go into the spinal cord, and which would further increase the tension. And as we are contracting this quadricep tendon, so what will happen to this joint? Flexion or extension? Extension at knee joint, right?
Extension of the leg. Yes.
Extension of the at knee joint. So it means the nerve which is taking all of this information which is coming back is going to be which nerve? Femoral nerve. Can I say that? Because femoral nerve is the one which is supplying your quadricep muscles. And in the patellar reflex, we are looking whether we have intact nervous supply of your quadricep muscle or not. Am I right? Hello?
Yes.
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 Okay, perfect. So can I say in patellar reflex, we are looking for at the activity or the pathway of femoral nerve, whether it is intact or not. Can I say that?
Yes.
Because femoral nerve is the one which is in your quadricep muscles. Perfect, right? Okay, so femoral nerve is going to supply the anterior cutaneous branch, which is going to supply the anterior medial thigh aspect, that is anterior medial thigh. Along with that, we have saphenous nerve. Do you guys remember saphenous vein?
Yes.
Hello?
It's the medial side
So one
of
of
the
the
leg.
branch of yes, perfect. So one of the branch of femoral nerve is going to be your saphenous nerve as well, which is going to be in close association with your saphenous vein. So if you remember for cabbage, we basically take the saphenous
We take the sample
vein,
from
right?
the
Not
vein.
have-
Yes. Saphenous vein.
That to have a proper bypass, right? So we can sometimes take the saphenous vein, right? But it can lead to compromise of the saphenous nerve, which is branch of femoral nerve, moving in close association with your saphenous vein. So this condition is going to be called as saphenous vein stippling, right? Whenever the nerve is compromised. So that's a simple thing, but you should just know this thing really. It's really important, the patellar one, right? So we discussed that.
It's purely sensitive nerve also. Then. Femoral nerves further going to converted into the saphenous, which is the purely sensitive nerve.
Yes. Okay. So yes, that's basically a branch of your femoral nerve. You only have to know that, and it's run in close association with your saphenous vein, right? So we were discussing about patellar reflex, right? We discussed whenever we just strike the patellar tendon, it's going to increase the tension within the muscle. This increased tension is going to be taken up by into your spinal cord, since it's a reflex and via femoral nerve. It's going to lead to further increase in the muscle tension, which is going to lead to kick off the leg, which is a patellar reflex, right? So if you do not have proper femoral nerve, can we have patellar reflex?
No.
No.
And along with that, there would be problem with flexion of your hip muscle, your hip joint, right? And
Yes.
flexion at knee joint. Okay. The other important thing which you should just keep in mind, really important, if you guys remember, you have a lot of you were MCQ even in the cardiovascular section as well. The mnemonic was NABL. Remember? Nerve.
Yes. From
lateral
lateral to
we
medial.
have,
You can
yeah, from lateral to medial, we have nerve, artery, vein, and lymph nodes, right? So this is your nerve, artery, veins, and here you have your lymph node. That's the mnemonic, right? So sometimes if you want to anesthetize your anterior, for example, if I'm doing any kind of surgeries here, right, in the anterior leg, so we have to anesthetize the femoral nerve, right? How do we do that? That's really easy. First of all, you have to look for the artery, and we know that it lies lateral to the artery. Nerve lies lateral to the artery, right? And we know that artery pulsates, so we are going to look for the pulsation, and at the lateral aspect of that pulsation, we are going to give a block, femoral nerve block. If we need to do any kind of surgery in the anterior, yes, in the anterior. Okay, let me just ask you another MCQ. Okay, something related to this. If we have an individual and we are just if we are just inserting for percutaneous intervention, right? We are using femoral artery. For example, if I just did it above the ligament, what's going to happen in that case?
will penetrate peritoneum.
Retroperitoneal.
Retroperitoneal hemorrhage, and it's really difficult to control that, right? So it means that for PCI, we have to, for example, if we are just taking of your heart and you are just inserting a catheter kind of thing. So we have always to do, we are going to always do it below the ligament, right? Below this inguinal ligament. Hello? Hello?
Yes.
Okay, so if you want to insert any kind of catheter, or so it must be below the ligament. So you have a lot of MCQs. If you just did it above the ligament in a femoral artery, it can lead to retroperitoneal hemorrhage, which is really fatal, and it can lead to death. Okay. So this was about some of the questions from your GI. Again, you're going to see that them there. Okay. Then you have your sciatic nerve, right? So what is your sciatic nerve? Remember, sciatic nerve is the largest nerve which is going to supply all of the posterior aspect of your leg. All of the posterior aspect of your leg, right? Sciatic nerve, when does the sciatic nerve get damaged? Really important, one of your UWOT MCQ. Whenever you have posterior dislocation of your
Hip
what?
joint.
Hip joint.
Femur. At hip joint, whenever the femur get
And femur
posteriorly,
fracture.
sciatic nerve is going to be damaged. Sciatic nerve is the largest, having 2 centimeter of width. So in this slide, we are going to discuss the sciatic nerve supply after here, after your leg, right? So this is going to be discussed in the radiculopathy chapter, right? So we are going to discuss the branches of sciatic nerve just below the knee joint, okay, at posterior aspect. Is it clear? So we have 2 branches of sciatic nerve here at the level of your knee joint, right? Okay, it's going to supply the hamstring and everything at posterior, which is going to lead to the extension of your hip and flexion of your knee joint, right? But we are going to discuss this portion of sciatic nerve in some other discussion in our radiculopathy, right? But here we are going to discuss the innervation of your sciatic nerve just below the level of your knee joint posterior, okay? So we have 2 branches. The one is tibial branch, just extending downward. The other one is common peroneal or fibula, right? So at the head of fibula, this nerve is going to, bifurcate, and it's going to give 2 branches, the lateral and the deep branch, okay? So sciatic nerve here is going to first of all give 2 branches. Which branch? The tibial branch, okay, and the common peroneal or common peroneal further is going to give a deep branch and a lateral branch, okay, or superficial branch. Let's discuss that. Okay, so here you can see common peroneal. Why do we call it peroneal? It's also known as common fibular because at the head of fibula it's going to be giving 2 branches, right? So you can see common peroneal nerve is going to give 2 branches. Which branches? At the head of the hamstring muscle, just forget that, the superficial fibular branch and the deep fibular branch, okay? The superficial is going to supply the lateral compartment of your leg. So it's really simple to imagine. If I'm supplying this lateral aspect of the muscle at the lateral aspect, what do you think, what would be the function of those muscles?
Inversion.
Dorsiflexion or emersion.
Eversion.
Eversion. That would
Yes.
be eversion.
Eversion.
Okay. Okay. The dorsiflexion would be for the anterior one. If we have muscles at the anterior compartment, it would somehow insert here. If I'm just pulling them, it would lead to dorsiflexion.
Yes.
Am I? And the muscles who are supplying at the posterior aspect, just like that, would be inserted somewhere here. So if I'm just pulling them, it would lead to plantar flexion. Am I right? Hello?
Yes.
Yes.
Okay. Let me just repeat it again. You have 2 branches, superficial and deep. Superficial is going to supply the lateral compartment of muscles, okay, and the deep is going to supply the anterior compartment. So the anterior, it's obvious that they are going to insert somewhere here on the leg. So if you are just pulling them, it's going to lead to dorsiflexion, right? So the deep is going to supply anterior, superficial is going to supply lateral, which is going to help in eversion of the foot. You know what is eversion? For example, if this is your foot, you have just laid flat on the ground. So just lifting up from this side, pulling the lateral muscle is going to lead to eversion. That's eversion. Is it clear? Hello?
Yes.
Okay, perfect, right? So we have deep fibular branch and superficial. Superficial is going to supply the lateral okay, it's going to lead to eversion. You don't have to memorize the name of these muscles, only knowing the lateral compartment. Deep is going to supply the anterior compartment. Just don't remember these names, which is going to lead to dorsiflexion, right? So my question for you is, whenever we have problems with the deep nerve, won't it lead to something called, yes, as in the hand
Foot
you were
drop.
having,
Foot
in the
drop.
hand we're having wrist drop. So what are we going to see here?
Foot drop.
Foot drop.
Drop.
Foot drop.
That would be foot drop. That make a lot of sense as well, because if we do not have dorsiflexion, the plantar flexion, which is the intact nervous supply, would dominate. It's going to lead to foot drop. Okay, so these were the nervous supply of your anterior and your lateral foot, right? So they're also going to supply the dorsum of the foot, as we know the common peroneal is going to supply the dorsum of the foot as well, right? Then we have our next one. Okay, so as they have mentioned here, how do we injure this nerve? That's very simple. As we know, they're bifurcate at the head of your fibula. So it's going to be injured while lying in the bed, a bed rest. It can just compromise your nerve. It can just impinge it along the surface of your fibula. Leg cast can do that. Fibular neck fracture can do that. We're going to be having foot drop. Why? Because we know that the deep one is going to supply the anterior. No dorsiflexion, plantar flexion is going to be dominated. The posterior are going to be supplied by the tibial. Now you know that, right? The tibial are going to be dominated, which is going to lead to foot drop. Okay. And the sensation are also going to be lost at the dorsum of the foot and shin. Okay. So we have tibial nerve then. Okay. So we know that the tibial nerve basically supplies. Okay, this was your tibial nerve, remember? So it's going to supply the posterior compartment. We know posterior compartment muscles are going to come here. It's going to innervate your leg. So if you are just pulling these muscles, we are causing plantar flexion. Am I right?
Yes.
We are causing plantar flexion, and it's also going to supply this sensory, supply to the foot, right? Okay. So to the heel and the sole, you have the sensory supply via tibial nerve, and it's also going to supply the posterior compartment, whose function is going to be a plantar flexion, right? So the tibial nerve, it basically supply the posterior leg muscles. What are your posterior leg muscles? Let's discuss that. So we have the popliteus, small muscle present here in the popliteal cavity or fossa. We have flexor hallucis longus, flexor digitorum longus, tibialis, plantaris, soleus, and gastrocnemius, right? So it's not really important to memorize each and every muscle, but at least you should know that it's going to supply the posterior compartment of your leg. What's going to be the function? Plantar flexion and inversion. So that was your eversion, which we discussed, and this is your inversion, right? So inversion is going to be done by your tibial nerve, right? How can we have tibial nerve injury? If you remember the first one, the large Baker cyst. Did you guys remember? I just told you we're going to discuss it in our lower limb. If you have a big Baker cyst, resembles like DVT pain, remember? Found accidentally. Okay. So the Baker cyst, if compromise your tibial nerve. So can we have plantar flexion?
Yes. Sorry. No. Not
No.
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 Plantar flexion. Loss of top flexion. Flexion is also going to be affected, and loss of inversion as well, which is a function of your tibial nerve. So we have tarsal tunnel nerving. So same as the carpal tunnel and the Guyon canal we discussed in hand, we have something called tarsal tunnel in the leg, right? Which contain this tibial nerve. Okay, it's present just at the heel. You can just look for some pictures on the Google. You can just search them, right? So often if they get dislocated or fractured, we can have compromise of tibial nerve, and again, symptoms are mostly going to be sensory, that is pain, burning, numbness at sole of foot, which is basically the distribution of your tibial nerve. Okay, so that's
It's called posterior compartment syndrome also. We have to do fasciotomy there.
perfect. If we have posterior compartment syndrome, so what is posterior compartment syndrome? What if any kind of abscess or anything leading to a lot of pressure in the posterior compartment, right? A lot of pressure. As you can just relate it with carpal tunnel syndrome, having, let's suppose, glycosaminoglycans accumulation and compressing your nerve causing carpal tunnel syndrome. So for example, if the posterior leg has any kind of abscess, anything which is increasing the pressure there. So what's going to be the first step? One of your UWorld MCQ as well. Thank you so much for remembering me that. You are going to undergo the fasciotomy. What is fascia? Fasciotomy, you are going to cut the fascia to release the pressure there, right? So as the pressure is released, the symptoms or the, which is due to compression of the nerve are going to be, reversed. Okay. The last one is
Sir,
pudendal
it
nerve.
is only for posterior. Sir, it is only for posterior compartment, not anterior or lateral.
You can have, you can have this increased pressure in any compartment of your body. Remember that, not only in the posterior leg, right? So you can have this. So fasciotomy is going to be the first line. Like for example, you can have anterior compartment or increased pressure in anterior compartment of the hand as well. For that, again, you are going to cut the fascia in order to release the pressure. Okay. So it's not obvious that we are only going to have in the posterior compartment. Okay. Okay. The next one is pudendal nerve. If you guys remember, we discussed something about pudendal nerve in our, in which module? In the UWorld of your, okay, let me just remind you, UWorld of your renal section. Remember? And the first aid as well. Hello?
Yes, sir.
Okay. Okay. So pudendal nerve. Remember the pudendal nerve was basically supplying which muscles, if you remember?
Perianal.
Levator and I
Right
muscle.
here.
In the renal, we discussed levator and eye muscles, and we discussed with multiple delivery. We can have weakness of levator and eye muscle due to which what we can have. Remember it?
Difficulty in urination.
Or yes, what was the first line of treatment for that with exercises?
Kegel
Kegel
exercise.
exercise.
Physical exercises. So you are already aware of this pudendal nerve, right? So pudendal word means HM. It means it's going to supply the area that is genital area, right? So muscles of perineum, external urethral sphincter, external anal sphincter, and levator and eye. And essentially, it's going to be penis, clitoris, and skin of perineum, right? So you can see these are the muscles which they're going to supply the levator and eye muscles along with that. Okay, so you can just see the picture, and we discussed that pudendal nerve is going to be damaged in multiple vaginal delivery, right? Which is also going to lead to the stress incontinence. Remember which kind of incontinence were we having there? Stress incontinence, right?
Stress.
Stress incontinence.
Because we discussed that the levator and eye muscles are also responsible for making your external urethra stuck to the wall, so in order to give a proper strength and the urine won't release. But as we have weakness of those levator and eye due to multiple delivery, the pudendal nerve is damaged or compromised, we can have stress incontinence. Like whenever we have increased abdominal pressure, it would lead to urination, which was stress incontinence, right? So perineal, fecal and urethral or urinary incontinence, because both of the external anal sphincter and external, urinary sphincter is going to be under the, control of your pudendal nerve, right? And we discussed what are the first line, treatment for that. The first line treatment are your Kegel exercises, right? First line. Okay, so you know that it's really important. You're going to have a lot of keyword MCQ in it as well. For example, if someone is having or a lady is having any kind of vaginal delivery, right? So sometimes you are also going to give them a pudendal nerve block in order to avoid pain. So for that, what we are going to do, which landmark are we going to use? Ischial spine. This is your ischial spine, right? So pudendal nerve basically runs over this ischial spine. So you are going to look for like through the vaginal opening. You are going to palpate this ischial spine, and there you are going to give the block. So in this way, you can block the pudendal nerve, which would avoid pain. Now this is the lithotomy position. You are going to palpate through vagina, this area which is your ischial spine, which is a landmark for presence of your this nerve, that is pudendal nerve. So here the pudendal nerve block can be given in vaginal delivery, right? So that was all about today's lecture. So we are only left with 2 topics for tomorrow, and tomorrow we are also going to start our physiology as well, right? So lumbar radiculopathy, which is really high yield but really small topic, and along with that we have a small topic of hip joint as well, right? So this was all about today's session. Okay, and thank you so much.
Sir, can you,
And-
sir, can you please share
Sorry.
yesterday's lecture?
Yeah. Okay, let me just do it now. Okay,
Hello.
thank you so much.
Thank you.
Hello.
Thank you. Have a nice day.